My name is Wissal Rouabeh, and I'm a cardiac surgeon in the University Hospital of Sahloul, Tunisia. Can you hear me, please?
Yes, we can
Hello?
hear you. You can proceed.
Okay, that's wonderful. Well, it is a case report which was published last year. It's a rare case, and let's be started. Well, as you know, that mesothelioma is a rare malignancy that arises from pleura, peritoneum, or tunica vaginalis, mesothelial lining. But primary intracardiac malignant mesothelioma is a rare illness. And due to the low incidence and few instances that were recorded in the literature, that's why we are presenting this case. Well, let's move to the case presentation. I can see the e-poster that I've sent you, so it can be clear to the audience now. Can you hear me?
Yes, we can hear you.
Okay. Well, it's about a 44-year-old lady who had no previous history of cardiovascular illness, and she referred to the Department of Cardiology for worsening dyspnea, palpitation, and recent syncopal episode. The physical check revealed normal blood pressure, regular rapid heart rates, and there were no abdominal findings on the pulmonary auscultation, but she had an apical diastolic murmur. The chest X-ray revealed a bilateral pleural effusion, and the EKG showed a sinus tachycardia. According to the echography, there were a massive mass within the left atrium linked to the side wall, causing a mitral valve blockage with a mean pressure gradient of 18 and grade 1 mitral insufficiency. The left atrium and the left ventricle were both dilated, and the pulmonary artery pressure was high around 18, with grade 2 tricuspid insufficiency. The CT scan confirmed the findings that I have mentioned and showed a big mass emerging from the left atrial lateral wall and extending to the posterior mitral leaflet, blocking the mitral orifice. The MRI showed a tissue mass infiltrating the atrioventricular groove, responsible for severe mitral stenosis at the position of the posterior mitral valve. The mass measured around 2.5 to 3 centimeter and presented a hypotense signal in T2 and ASO signal in T1 with late and partial enhancement after the administration of the paramagnetic contrast agent. Well, in this case, clinical and radiologic criteria supported the urgent surgical treatment decision. The patient was transferred to our department for urgent cardiac surgery. Sternotomy, of course, was done by caval cardiopulmonary bypass with cross-clamping aorta, of course. And anterograde normothermia cardioplasia was initiated. Right arteriotomy and transeptal approach were used to reach the tumor. A 4 centimeter wide white mass emerging from the posterior leaflet of the mitral valve and extending to the mitral annulus to the atrioventricular groove was found, of course. Both tumor and mitral valve were totally removed. The posterior ring of the mitral valve was weakened by the tumor excision, requiring its strengthening by a pericardial patch, and the mitral valve was replaced by a mechanical prosthesis. A sample of the tumor was subjected to frozen section examination, and the resected specimen's histological investigation confirmed the diagnosis of malignant sarcomatous mesothelioma. As it showed, I sent you the picture in the e-poster, you can see it. Well, the recovery period was unremarkable. On the 10th post-operative day, the patient was released. 3 months later, she no longer complained of dyspnea or palpitation following a satisfactory echographic examination. But during the course of her chemotherapy treatment, the patient was subsequently relocated to the cardiology department after a period of 9 months following her surgery. Transthoracic ecography and transesophageal ecography were conducted, which indicated the reappearance of the tumor that caused a significant mitral prosthesis stenosis. The course of the patient was characterized by the emergence of cardiogenic shock, unfortunately, that was unresponsive to medical intervention, ultimately culminating the patient's demise. Well, as you know, that primary cardiac tumors are uncommon, and specifically malignant mesothelioma accounts for around 4% of these tumors. This type of tumor, mesothelioma, generally affects the pericardium. The frightening accounts in the literature correspond to an exceptionally uncommon occurrence of primary intracavitary cardiac mesothelioma. Well, surgery should be undertaken in these cases as soon as feasible, because there is a danger of this disastrous embolization or blockage or of the valve orifice, which is most prevalent in the setting of a large atrial tumor. The goal of surgery is to resect the whole tumor with adequate margins, which is seldom attainable. Patients who do not require total resection might benefit from palliative debulking for relevant or rapidly increasing symptoms. In the case of an unresectable malignant tumor, cardiac transplantation is still a possibility. Well, due to late manifestations of such tumors, difficulties to fully eradicate the tumor by surgery in certain cases, and poor response to radio and chemotherapy treatment, malignant mesothelioma has an extremely dismal prognosis with few viable treatment methods. As to conclude, due to lack of data, no evidence-based guidelines are available. The most successful therapy is still early detection and surgical removal. Of course, nevertheless, due to the tumor's local aggressiveness, this is seldom achievable. And that's it.